The physician founder of Physician Pre-Sentence Report Service. We're physician prison consultants. My phone number is 240-888-7778. Tonight I'm going to talk about in prison, your medical record is your pre-sentence report. When it's in your pre-sentence report, can act as a medical referral. So this is an article that I posted. It's on the front page of the website. And it's going to go into medical care in prison, in federal prison, this year, 2026. So the topics I'm going to review, it's going to be the importance of the medical record, the pre-sentence report, working as your medical referral, what to expect in patient care. There's categories and scope of care. Steel-toe safety boots that are in all the prisons. That's a good thing that protects your feet, but it's also not really good for those that can't wear steel-toe boots or need some sort of cushioning. The needs of an aging population is hitting everywhere. Mental health programs have limited locations nationwide in the federal system. Psychology programs too, in addition to having limited locations, you have, with the staffing shortages nationwide, you have nurses, medical staff, teachers, teaching staff being augmented into being correction officers. So it takes away from the ability for access to medical care or school programs. Medication availability, DOJ and OIG reports the dark side of medical care in prison. Compassionate release. This is a very good brief, Amakori, but I'm not an attorney. I'll just provide it for you for research. Where judges had to intervene. Mental health, preventable deaths, measles. There's a checklist out now by the CDC for correction facilities, prisons, on how to act. The problem is that when you suspect someone of getting measles, everyone, if you're in school, should stay home. Everyone needs to be isolated. Well, that can't happen in prison. And the Bureau of Prison encourages inmates to use what's called the administrative remedy process for grievances. And that's important. It's fine and dandy. Unless you're someone that's so ill, you can't even defend yourself. So it's going to start with preparation for your pre-sentence interview, your medical record. Long before you get to your pre-sentence interview, it's so important to have all of your records available, especially if you need to continue medications, continue medical treatments. You need to start preparing to get copies of everything. These doctors and hospitals, they can't drop what they're doing just because you have a sentencing date coming up or a pre-sentence interview date. You need to start really early. And so when it comes to providing medical care to individuals with unique medical conditions, in the Bureau of Prisons, it's crucial to have a comprehensive medical history that includes all of your medical records, including reports of surgery, including path reports, pathology reports, diagnostic. These are X-rays, CT, MRI scans, ultrasounds, EEGs, EKGs, PET scans. And you can get these also on a CDC to take in with you if you self-surrender, and then request of the correction staff when you surrender, as you have legal mail, and that's where your medical records you're bringing with you, ask them to pass that CD on to medical. And so it is so crucial, because if you don't have the bare minimum, which is a well-developed medical record, even if you go into prison with this, there's no guarantee that you're going to get access to care. So going in without all of this content makes that much more difficult. All recent blood tests, prescription, drugs, medical devices. Medical devices need a prescription, hospital records, treatment plans from your treating physicians. Ensure that the patient inmate receives appropriate care. It's essential to obtain all relevant documentation and contact information for your physician's name, phone number, email addresses, etc. It's advisable to prepare thoroughly for this pre-sentence interview. In addition to medical, the person who's interviewing you has the judge's ear, and they're going to make a recommendation for placement and the length of your sentence. And they can, tell the judge that, that you're a jerk or you're a nice guy. And so you want to make an ally of this person, especially if there are concerns regarding your medical care raised by the patient, by your client or the patient's attorney or treating physician. Doing so will enable you to strategically plan before you get to that interview. So that, for example, if you need to have an orthopedic surgery and there's no time because you're going in, you're sentencing and you're going to, you just don't have the time, but you've had all your pre-admission testing done, then if you have all of that, your attorney can request a federal medical center that does orthopedic surgery. But you don't want to just go into a federal medical center because you think you're going to get the best care. Medical centers in prison are not like your hospital. And so there's violent, non-violent people there. And in addition, there's a staffing shortage. And so you're not going to get better care because you're going into a hospital there. Your comprehensive autobiographical narrative should include your entire medical record. If you use a CPAP, have tinnitus, balance issues, you're taking medications or other medical concerns, all of these charge notes, if they affect your ability to be in a lower bunk versus higher bunk, you need to have everything documented. In your PSR, does it say no top bunk? It's got to be physician. It'll hopefully be physician documented. This is a little too small to see, but you don't want to do anything in prison to injure yourself. You do not want an upper bunk if you have a major joint replacement, have an unstable gait, or older. This includes history of back pain, shoulder pain, and foot pain, pathology or surgery ringing in your ears, which is tinnitus, or other medical conditions. If you're unsure, give me a call. But you don't want to wind up. I mean, there's a fracture here on someone who had a hip replacement. And this is how you're going to have to get into an upper bunk. It's not in your best interest. Some people I know will love to go into the upper bunk. Good, great. I don't know that that's appropriate for everyone. Outside of prison or at home, if you're not well or experience pain, you have a problem, you can't work, you're going to seek medical care. And the doctors are going to assess your injury. They may draw some blood, they may order x-ray, CT scan, and depending on the severity of the injury, you may be admitted to a hospital or transferred to a specialized center. It's important to note that in prison, access to specialists may be delayed or denied, underscoring the importance of prevention. In the Federal Bureau of Prisons, it could take you 3 years to request to get an outside medical specialist. And by the time you get to that specialist, have your visits, are returned to the prison, it can be as much as 3 years. The clinical director or the BOP is not obligated to follow their own outside specialist recommendation, period. Recognize you're going to a place where you have no control. You don't want an upper bunk if you have muscle weakness, unstable gait, like I reviewed, degenerative joint disease, sciatica, neuritis, are older or have other medical conditions that contribute to an unstable equilibrium. Your pre-sentence report should provide documentation from your surgeon, your family practitioner, internist, or other physicians stating why a top bunk is out of the question for you and why. Bureau of Prisons outside medical specialists. I covered this already. Getting medical care inside is not like we're used to. Expect not to have specialty care provided, especially if you have that second opinion. It could take 3 years, 2 to 3 years, because the facility's clinical director is not obligated to follow those recommendations. And here it's a little small, but it's a slide from a presentations that I give to attorneys. Consider comprehensive pre-sentence. Consider this gathering. Consider your pre-sentence report like insurance. Nobody likes to have health insurance, automotive insurance, car insurance. It's just other payments. You hope you don't need it until you do. The pre-sentence report, it can act as your medical referral. Now, this is an article that I co-authored rather, availability of treatment and rehabilitation in federal prison. And this is the article right here. But it covers all of the different parts of healthcare. Patient care. In federal prison, medical care is categorized by care level. There's care levels 1 through 4. Care level 4 is a hospital type care. You should need to have to get in there either impending surgery or you need nursing care 24/7, 365. Care level 1 for individuals under 70 that have a minimal need to get to see a physician, maybe twice a year. Care level 2 is like your family practice, a nice internal medicine practice. You see the physician and their staff possibly quarterly, no matter your condition. If you're stabilized under medications, that's okay. Again, you're seeing the doctor quarterly. Care level 3 means that you're just shy of getting into a medical center, but you do not need the care every day, 24 hours a day. There they may have inmate companions, which help those that are not prepared for they need assistance with activities of daily living, which is eating, sleeping, bathing, going to the toilet. Or there's something called prison activities of daily living, where it's someone who's getting a little older and all of a sudden, guards are shouting, get out of bed, and they don't want to get out of bed. Or, stand up or standing count, and someone just doesn't hear it or gets nervous when that happens. And then they get in trouble. Or maybe the person is at a level where, they're just kind of wandering around and they'll wander into other inmate spaces. And in prison, respect is a $25 word, and everyone's where they live. That's their own personal space. So it can wind up getting someone in trouble. Co-payments. If you have no money at all, you're not going to be responsible for co-payments, and the medical care will be provided. But if you cause injury to someone else and they have to get treated, you're going to pay as co-payments for their care. In addition, and this is where it gets a little squirrely, if you have, a disease and you need to see the doctor not feeling well, the only way you can get an appointment, on paper it is, at least in policy, is through a referral from the medical center themselves through scheduled appointment. And so if you cannot wait till the next day to get in, and a correction officer creates that appointment for you, you're still going to have to pay a copay if the medical staff deem it necessary. Different articles here you can open up. Cut rates care in systemic care. This is our article regarding cut rate care, the systemic problem shaping healthcare. In correctional healthcare systems, care is secondary to controlling costs, avoiding lawsuits. Although I just did an article that if in fact can be proved malpractice on the part of the facility, you can go after. There's been successful malpractice claim, a problem plaguing both private and public healthcare delivery. Program statement. This is regarding patient care. This covers an overview of how medical care is received in prison, and I'll open it up right there, and you can go. It's programs. These program statements, by the way, this is the Federal Bureau of Prisons, their law, and they have to abide by it. And so this is where they go through this, and I'm not going to go through the entire purpose and scope of the patient care, this program statement, but you can Google it online. They have payment for healthcare services. I just reviewed a little bit. Generally, if you are an inmate described in this code, you must pay a fee for healthcare services of $2 per healthcare visit if you received healthcare services in connection with a healthcare visit that you requested. And then there's a link here specific to this particular link, program statement regarding copayments. And again, I'm not going to read the whole thing to you, but it explains it. And second, which I discussed, you're found responsible through the disciplinary hearing process to have injured an inmate who, as a result of the injury, requires healthcare. There's categories and scope of healthcare. And again, this goes to the article that I co-authored on the availability of treatment care in federal prison, the critical role of the pre-sentence report. Life-threatening conditions. Life-threatening conditions require immediate attention to sustain life or critical bodily functions. The Federal Bureau of Prisons classifies these as medically necessary, acute, or emergent. They are heart attacks, severe trauma, head-like injuries, hemorrhage, stroke, detached retina, sudden vision loss, or complications of pregnancy or labor. Medical care that's necessary but not urgent. Serious deterioration leading to premature death. Significant reduction in the possibility that if there's repair later without the present treatment, then that repair may not be available. In other words, if you need to have a procedure done today because 2 years from now it's not going to work, this is a problem. Significant pain or discomfort, which impairs an inmate's participation in these activities of daily living. While not immediately life-threatening, without treatment, the patient's overall health and/or activities of daily living may not be maintained. Medically appropriate, but not necessary, to improve the person's quality of life. Joint replacements, reconstruction of the anterior cruciate ligament, treatment of non-cancerous skin conditions like skin tags or lipomas. This is okay, but I'll put a caveat here that how do you know that a skin lesion is non-cancerous if you don't biopsy it? I don't get it. But who am I to say, other than someone trained for 30-some years, if not more, in medicine? These always require review by the institution's utilization and review regarding the risks and benefits of treatment, available resources, money, natural history of the condition. Hopefully it's in your pre-sentence report, and the effect of the intervention on the inmate's functioning in his or her daily activities of living. These are considered elective procedures to improve the person's quality of life. They may be permitted, but there's no guarantee. And for all of this to happen, you need to be able to get in and see your medical center, the medical staff where you're at in a timely fashion. That doesn't happen all the time. Of limited medical value, minor conditions that are self-limiting, cosmetic procedures, removal of non-cancerous lesions, unless you have a history of skin cancer. Two issues are present. Hopefully, the prison healthcare provider has this type of training to recognize the cancer. And two, that your pre-sentence report is detailed. Extraordinary organ transport or donor, those are considered investigational. You won't always get steel shoe boots or steel-toed safety boots. NIH, as well as the rest of the medical world, understands that in addition to the width of a shoe, it's the insoles that are in the shoe that reduce ulcers by reducing the shear force on the bottom or plantar aspect of the foot. And so medicine is both an art and a science. While the implementation of steel-toed boots protects the institution and a majority of the incarcerated persons, a small but significant portion of the population may be harmed, however rare this may be. And so, you need to watch. If you have a foot that has hammer toes and bunions and, your joints are deformed, you're not going to fit into a steel-toed shoe that easy. If you have diabetes or immunocompromised or have Raynaud's, which is sensitive to cold, Going into a steel-toed shoe is not the smartest thing. There is no insole. So they're going to leave you to buy an insole. Well, there are specific insoles that come with diabetic prescription shoes that are much better and are for the purpose of preventing foot ulcerations. The Bureau of Prison States Program Statement 306031 Patient Care, which I already opened up for you, page 58, that it is responsible for providing each of them with a pair of safety shoes suitable for their job. They will make custom shoes, not safety shoes, or orthotic devices available if medically necessary. Is that going to be in your pre-sentence report? To accommodate a significant foot deformity to reduce the risk of foot injury in individuals with impaired sensation. The caveat here is that in a large bureaucratic institution, the patient inmate may have to either pay their copay in order to be seen for that unscheduled visit or wait for a staff to provide the referral. Either way, once prescribed, if they're going to get you the shoe, it can take a long time. Are they going to let you just wear sneakers? I hope so. The headline image I've chosen for several reasons. Safety-toed boots, safety boots with a steel toe provide protection. But after 30 years in practice in this field, other forces are of greater concern. To start, the inner sole at the bottom of the boot has to have significant padding to cushion and protect the foot from shear forces that over time can wear down the skin's protective padding. This is page 58. Here it reviews footwear, and the clinical director must approve, you can't see this unless you're looking real closely, for the purchase of custom shoes or orthotic devices. Well, I mean, they may not want to do that. HCPCS, which is a code in medicine for diabetics, fitting and including follow-up of custom preparation and supply of off-the-shelf shoe manufacture to accommodate multi-density inserts. Meaning, we'll open this up here, that this is a long description of diabetic shoes, what's covered, diabetic measuring for diabetes, diabetic. These are all topics that physicians look at and that your doctors need to see. Therapeutic shoes for people with diabetes. I'll open this here. License agreement, the American Medical Association, procedure terminology. This goes through all the codes and what goes into this particular shoes. So it's crucial for you to have this information. Then there is a steel-toed shoe. While available in widths, new boots, being what they are, take time to break in. During that time, the person's toe is rubbing against the hard leather steel binding and is a recipient for potential problems. In other words, right where your toes enter the toe box, once that protective lining wears down, your foot's going to be against steel, no matter how rare. Over time, with wear, the foot through normal gait could begin to rub against the steel toe box, no matter how rare this is. This comes from their management of diabetes, and it goes through clinical guidance on getting the correct shoe gear. The patient inmate does not have to be controlled or an out of control diabetic. They could be pre-diabetic, have peripheral vascular disease, Raynaud's, just to mention a few. Therefore, for those who slip through the care level cracks, some may need to have a toe or two amputated due to infection. But here's where Murphy's Law kicks in. Once you start getting amputations due to diabetes, it's a never-ending course in surgery. In other words, if they take away some of your toes, you're going to have eventually you go back and you have to have more surgery. So they take the remaining toes and maybe the end of the foot, and until it works your way up to a below the knee replacement. I'm not saying it happens all the time, but Murphy's Law happens more often than not. The needs of an aging population. They can participate in activities of daily living, some. In some locations, there are inmate companions to assist where needed. You want to make sure. Extreme heat now can be deadly, whether you're young or old, but affects seniors and immune compromised most. And so here is an article. I link it. You can click on this on my website and open it up to the actual article itself. But without a consistent access for relief or safer environments, incarcerated people are punished with deadly heat, increased biological threats, and flimsy emergency protocols. And so it goes, it gets into a little bit more detail. Climate change. The Prison Policy Initiative, again, the same article, in combination with heat waves and extreme weather events, are now becoming more commonplace. And while states like Texas and others in the South are seeing staggering high temperatures increasing at night, along with the unusual increase in severity of normal experienced weather events. In those states, the Northeast has experienced also higher mortality rates. And then here is a little bit of video, a slide from the presentation I do, 5 specific PAD, prison activities of daily living: dropping to the floor for alarms, standing for head counts, ambulating into a dining hall. Can they make their way to a dining hall, hearing and understanding orders that are being screamed at you from the staff, climbing up and down stairs or up and down from the top bunk? Responding to questionnaires, 69%, almost 70% described at least one prison activity of daily living that was just disturbing. 28% self-reported memory loss. And so it can result in fights, assaults, self-injurious behavior, disciplinary actions, and eventually possibly putting that person into isolation. Here's a video that you all can open up. It goes through the temperature heat waves in prisons themselves. Mental health programs. Mental health, including psychology, and almost all of the psychology type programs, mental health programs in the Federal Bureau of Prisons, in conjunction with First Step Back, they have a limited number of locations. I'm going to go through just a few. The Female Integrated Treatment Program supports female inmates with PTSD, mental illness, substance abuse by providing comprehensive treatment, plus the access to RDAP programs. In a therapeutic setting, located in a low security institution, the program serves about 200 inmates and is staffed by 3 psychologists, 4 treatment specialists, a social worker, and the unit team. We don't know that the staff is going to be 3 psychologists, 4 treatment. I mean, they're just maybe short staff. Skills program. This is for inmates with a documented history of neurological deficits from acquired brain damage, fetal alcohol syndrome, the part of the autism spectrum disorder, and or remarkable social skills deficits. Stages program. Residential. The Stages program for inmates with borderline personality disorder, typically characterized by prolonged restricted housing placements, multiple incident reports or suicide watches, and a pattern of disruptive behavior. Borderline personality disorder is a mental illness that severely impacts a person's ability to regulate their emotions. Treatments and therapy range from talk therapy to medications. I don't know that we're going to get much talk therapy in prison. The National Education Alliance for Borderline Personality Disorder, they have recommended treatments and they have a video series for professionals. I don't know that the employees in the Federal Bureau of Prisons, they barely have time to do what they're doing to become proficient here. Skills program. It's a program for inmates with intellectual disabilities, neurological deficits, social deficiencies, autistic. The staff works closely with psychiatry to ensure participants receive appropriate medication and have the opportunity to build a positive relationship with the psychiatrist, if there's a psychiatrist. The BRAVE program. This is to facilitate favorable institutional adjustment. Participants interact in groups and attend community meetings while living in housing units separate from general population. Life Connections program addresses religious beliefs. So they have different programs that they're trying to implement, but due to the staffing unsurety throughout the entire Bureau of Prisons, a lot's going to depend on where you go, and you can request a placement. Psychology programs, we reviewed BRAVE. The Challenge program, it's a male inmate facing a high security penitentiary with a diagnosis of either mood, anxiety, schizophrenia, delusion, or substance-induced psychotic disorders. I'm not sure what they're going to do. This is just, to lighten the conversation. But if you talk to God, you're okay. You're praying. If God talks to you, you have schizophrenia. Mental health step down is a program is for men and women who lack the skills or function in general population. Resolve, it's for male and female with a diagnosis of mental illness related to physical, mental, and or domestic violence or traumatic PTSD. Skills, and we reviewed stages, is an inmate with serious mental illness and a primary diagnosis of borderline personality disorder. So they have different of these programs they say that they can do a little bit of everything. I don't know. This goes to an article that I thought was linked here, but it's not. Sex offenders are at the bottom of the prison hierarchy and often face hostility from other inmates. The BOP assigns them to higher security facilities as needed, particularly for general population. Upon arrival, though, new sex offenders are frequently asked about their offenses by bunkmates, which can lead to potential isolation or violence once the crime is revealed. This may result in most of their time spent in solitary confinement, which is not a place anyone wants to be. Therefore, safety considerations suggesting placing them in facilities with a sex offender management program is the best way to go. And we have here, this will pull up the link, and on page 30, excuse me, let's see here, and page 35 goes to the different sex management. Let's see here if I can pull it up by page number. And there is no page numbers here. So I can't do it here, but I can do it potentially here. Let's see. Here we go, 35. So the sex offender treatment program is provided as a program component for the sex offender management program. All these institutions are required for sex offender services, mandatory program assignment for inmates, and the locations for the sex offender management program is limited. Carswell, Whitman, Devens, Elkton, Englewood, USP Mariana, Petersburg, Seaganville, and Tucson. So it's available for you to see here. And let's go back. No, over here. Sex offender treatment program, residential for single sex crimes, first time offender, non-residential for history of single sexual abuse, many first time offenders. Butner doesn't have a sex offender program. What they do have is a psychology doctor internship for considered where the interns are have specialized in going to school for psychology or psychiatry. And so their internship is here where they're interacting with sexually dangerous persons to learn as part of their education. Female integrated program we reviewed. Medication availability. The Bureau of Prisons will not accept orders from the courts regarding an inmate's requirement for medication or medical treatment. And so down here, number 9 is where that order is located. If you can, I can't make that larger, but you can if you go to the website. Medications fall into 3 tiers, as I call them. There's on formulary, which is tier 1. These are generic medications that they have. Even if it's in your pre-sentence report, you may not get it, but you at least want to have it in your pre-sentence report. Second are non-formulary. These are generic medications that the pharmacy is instructed not to provide. So in other words, if your medication falls onto that list, the BOP, the Bureau of Prisons, their formulary has over 3,500 drugs. You and your physician, possibly your attorney or me, need to go through the drugs with the doctor. So the doctor needs to address if you need a certain medication and it's on the non-formulary part of their generic list, the doctor needs to review every drug that is on the on-formulary generic list and say why it does not work for you. And it's been tried or hasn't been tried. And why, for continuity of care, quality of life, that you need the medication. Lastly, they're not available. The 3 tiers, 3,500 drugs, we just reviewed that. Generic medications, as most of us know, but not everyone, is that there's many generic manufacturers per drug. So the same drug made by different manufacturers can differ in size, shape, and color. It's crucial to inform the clients that their generic medications may differ before they get to prison. Here we go. This is what part of one of the pages of the on formulary works with. Tier 1 is available, but you may not get it. This opens up. I'll show you right here. This is the on formulary list. There's hundreds, thousands of drugs here. Next is, hold on. Okay. Tier 2 is a non-formulary list. And these are going to be usually denied if they're not addressed in your pre-sentence report. Non-formulary medications require a lengthy pre-authorization process, often taking 6 months or more. You don't want to have to wait that amount of time. Defense counsel should ensure complete medical records are submitted to the Bureau of Prisons and the treating physician is involved in the pre-sentence report preparation before sentencing, before the interview, to facilitate this pre-approval process. The medical record that is being incorporated before you get to the pre-sentence interview should reflect what all of the formulary drugs that were available, why they were not effective, that they had been tried, and why the medication you're on is required for quality of life and continuity of care. Tier 3, not available. They're just not. Third tier, the Bureau of Prisons can prescribe what's called therapeutically equivalent but chemically different drugs to reduce cost, increase efficacy, enhance access, and improve inventory management. Essentially, they should have a similar outcome, but they're chemically different. By this point, though, the legal team and the current treating physician may have to begin to address in your defense strategy why this medication is needed to maintain continuity of care and quality of life. Department of Justice and Office of Inspector General reports. OIG inspection. Here, the efforts to place people closest to home. Conducted in September 2025, the placement of inmates should be within 500 miles of their residence. The BOP, Bureau of Prisons, has been using a straight line method, kind of like the crow flies, where in actuality, the intent of the law was driving miles. And here, if you click on the link, audit of the Bureau of Prisons to place people on close to home confinement. Second, and this is much more complicated, OIG inspected SeaTac Medical Center. And this is a video that I can't summarize on my own, but it's worthwhile to see. You can go through and see why there's staffing shortages. There is where people have had they're not getting their insulin on time. They're not getting their routine medical visits on time. If they're getting blood drawn, they're not going to laboratories for so that they can be evaluated. This unsanitary conditions. The Department of Justice and the Office of the Inspector General identified serious issues at the Federal Detention Center, CTAC. And this is not just there, it's across the prison system, including inadequate healthcare, staffing shortages, contraband control problems, the shortage of healthcare staff and correction officers, common issues across many Bureau of Prison facilities has created significant operational challenges. Here, we have the OIG investigated prisons regarding let's see. This was inspecting Sheridan among the most concerning, alarming, a staffing shortage among healthcare workers. To read this, I'll pull it up over here. It's another report. It goes through Sheridan. Again, it's a similar theme. There are healthcare worker shortage, and then you're not getting treatment. I mean, and some of the nurses or whatnot that are there have to be sub in as correction staff. Devon is a medical center. Federal Medical Center had a problem. The Department of Justice identified several serious issues in Devon, notably shortages of healthcare employees and correction officers, which are issues many BOP institutions, particularly problematic for a medical facility, have created widespread and troubling operational challenges at the medical center. It significantly affects health, welfare, and safety of employees and inmates. We have evaluating prisons for colorectal screenings. The federal, again, I mean, I can click on all of them, but you can open each one. And this reviews colorectal screening practices and the follow-up, which is non-existent. So I read here, Department of Justice announced evaluation of Federal Bureau of Prisons colorectal screening practices. The evaluation revealed significant operational and managerial deficiencies that hinder proper screening and treatment for inmates. The Bureau of Prisons is to failure to provide annual screening poses higher risk for inmates, can lead to increased healthcare costs. In this particular case, it led to deaths, which I'll review a little bit further along in this YouTube video. And lastly, we have the Senate committee where Michael Horowitz, the Inspector General, was before the U.S. Department of Justice was before the Senate to review all of these findings. Should your client be denied medical care once they have self-surrendered, been remanded, or still incarcerated? Do they know what to do? Was their medical record comprehensive when provided to the probation officer at the interview? While this is hopefully rare, it does happen, as you have read in many cases. Then there's the dark side of medical care in prison. Women are twice as likely as men to experience PTSD. According to the World Health Organization, women's chances of experiencing trauma is higher. 10% of women will experience PTSD versus 4% of men. It's tough to say. There are sure symptoms of PTSD since no two people will have the same experience. And you can look up, there's 2 articles here. And again, here's another one on women not getting prenatal care or being still chained. It's without going into detail, because I don't want to say anything wrong. It's called Jail Care by Carolyn Sulford, MD. She has this book out. This is what she does. Jail Care is a moving and galvanizing story of pregnant women in jail and those responsible for their health. It's essential reading for anyone who cares about women, children, and justice. Compassionate release. This is the brief of Amicorby, and it had, I'm not pronouncing it right, but here it is. And it's put together by retired Bureau of Prison senior staff from wardens on down to bring attention to compassionate release for serious reasons. Questions presented: whether the Court of Appeals correctly determined that a petitioner had failed to identify extraordinary and compelling reasons that supported reducing his sentence under 18 U.S.C. 3582C1A1, where his motion relied on statutory sentencing amendment that specifically does not apply to pre-existing sentences. This is where judges had to intervene. In this instance, the judge held the Federal Bureau of Prisons in contempt for allowing this man to waste away. Not only was he dying in prison, not only did the federal judge several times order him to be released. When they finally released him, they brought him in a wheelchair in a van to Dallas-Fort Worth Airport, left him on a bench at the airport, and took the wheelchair. And he was soiling himself right there. And if it wasn't for people who helped him to his flight, and then his lawyer and family picked him up at the plane, and it's insulting. Here's Judge Blatstein, Federal Bureau of Prisons, for providing poor medical care. In this particular case, the prison this individual's pre-sentence report was perfect. The prison arbitrarily reduced the dosage of one of his blood pressure medicines. Then they gave him, when he was having symptoms, different medication that led other symptoms, including dizziness, at least one, possibly two transient ischemic attacks, which wound up in local hospitals and mini strokes. This is all preventable. But if he didn't even have the if he didn't have a comprehensive medical record in the pre-sentence report, it would have been harder for his judge, for his attorney, for his case in front of the judge to get him instantly released. Mental health, preventable deaths in prison. Mental health courts connect people to treatment and keep them out of jail, but they also come at a price of a guilty plea. And participant says it feels like coercion. This is a video that really goes into exposes. It's a documentation on mental health in a Mississippi state prison, worthwhile to view. Unnatural deaths in federal prisons require an autopsy. That's why most deaths in prisons, if you notice, are going to be considered natural. In other words, there's little scrutiny on whether something is labeled as either a natural death or unnatural death. But if it's unnatural, you need an autopsy. We're used to on the outside, potentially if you die, you get an autopsy, you find out why. NPR found cases where medical neglect, poor prison conditions, and a lack of resources contributed to these deaths. Families were given little information. NPR found the CDC says natural deaths happen mostly due to disease or old age. Yet, 70% of inmates who died in federal prison in the last 13 years were under the age of 65. The examples of natural deaths included an inmate at BOP Springfield, Federal Medical Center Springfield, who died after weeks of untreated digestive bleeding, and another in Missouri who experienced respiratory failure, later deemed a homicide. In another case, a prisoner collapsed while running and was hospitalized. His family, not informed by the prison, called multiple hospitals before locating him. The Bureau of Prison contacted them 2 days later, assuring them they need not worry. 2 weeks after his collapse, he died. They called it a natural death. Now we're facing measles. And I think that everyone has not everyone, but a lot of people have a very short memory. When COVID hit the United States or hit the world, but here in the United States, not everybody remembers that first 6 months in New York, where there were more people dying. They had to bring to hospitals freezer trucks for the dead. This resulted in a lot of misinformation about COVID vaccine, which then resulted in, now we have a Department of HHS, RFK, who is as anti-vax as they come. So now they poo-pooed measles. Well, measles is serious. And if your kids are having measles, then chances are their measles deaths are out of control. Colorado, Arkansas, North Carolina. So now it's serious. It's gotten to the point because you quarantine people. It's definitely, you don't let them go to school. But if you're an adult, it can also be harmful. You cannot quarantine persons that are in prison. So the CDC put together this checklist. I'm not making this up. Preparing for measles, know what to do, how to contact your health department, reviews facility standard operating procedure. I don't see one for measles in the Federal Bureau of Prisons. I saw it for COVID. The BOP lastly encourages inmates to use the administrative remedy process for grievances. This is a cheat sheet, if you will, but it goes from BP 8, 9 is with the warden, 10 is with the region, 11 is to Washington, D.C., 2241 is directly to the court. I know I'm covering it kind of quickly, but if you have a severe medical problem and you have the ability to fill these forms out, all you've got to do is do a BP 9. And after 20 days, if you don't hear from the warden, you could do the 2241 directly to the federal court. And if you're not able to do it, you can contact your loved ones are also able to get involved. And I have a whole separate YouTube and a separate page on my website to deal with this specific topic. I appreciate everyone taking the time to listen to me. This was long. I realize your time is valuable, but I'm grateful to have spent the time with you. I hope you all have a healthy and a safe day.